this nice introduction. So let's start with ECCO. So in RDS, the strategy of using a low tidal volume to limit lung distension and a high PEEP to improve oxygenation, known as a lung protective ventilation, resulted in an important decrease in mortality. However, despite lung protective ventilation, mortality rates remain high, around 40%. Failure to implement lung protective ventilation may be the reasons why these mortality rates remain unchanged. Barriers for achieving lung protective ventilation are hypercapnia and its related effects. So permissive hypercapnia can be one strategy since it can have beneficial effects on oxygen delivery and attenuation of inflammation. However, we do not know till what degree we can tolerate it or for how long, since it has also adverse effects, like a decrease in myocardial function, decrease in renal blood flow, and it is certainly undesirable in patients with elevated intracranial pressure. So an alternative strategy can be treating hypercapnia with extracorporeal carbon dioxide removal. Since, as we heard this morning in ECMO, we need high blood flow rates for oxygenation, and for ECCO, it works with lower blood flow rates, and this is due to differences in kinetics. So let's take a quick reminder at Gall's physiology. Oxygen, which is mainly transported bound to hemoglobin, displays a linear sigmoidal kinetics. And so assuming normal hemoglobin and normal venous oxygen, each liter of venous blood can carry only 40 to 60 milliliters of oxygen extra before the hemoglobin gets fully saturated. So this is why that oxygenation is dependent on blood flow. In contrast, CO2 is transported as dissolved bicarbonate, which has a linear kinetics and no saturation at all. So 1 liter of blood can carry more CO2 than oxygen, and CO2 diffuses more rapidly across the extracorporeal membrane due to its higher solubility. So considering that 1 liter of blood could carry 500 milliliters of CO2 in a perfectly efficient system, a half liter of blood would be sufficient enough to eliminate all the CO2 produced. In practice, this is only 25% of the CO2 production, and this is because CO2 clearance is dependent on 3 major factors. First, the CO2 diffusion gradient. Secondly, the artificial blood contact time, and the diffusion characteristics of the membrane. So we know that CO2 exchange is dependent on ventilation, or in case of a membrane, on the gas flow. It's termed the sweep gas flow, and sweep gas doesn't contain CO2, so it passes through the extracorporeal membrane, through a semi-permeable membrane, into the blood, creating a diffusion gradient. And this allows the CO2 to be eliminated. So the CO2 diffusion gradient is dependent on the CO2 blood content and on the gas flow. Secondly, the blood contact time, which is determined by the geometry of the membrane. It is normally made of hollow fibers, which when heparin is added, its biocompatibility will raise. And thirdly, the membrane diffusion characteristics, which are made of hollow fibers that are arranged in a complex mat. And you can see that the blood runs at the outside, while the gas phase is located at the inside. So blood flow through a circuit can occur in 2 ways. First, arteriovenous devices. These devices are pumpless systems, meaning that they use the patient's own blood pressure. There are 2 wire-reinforced cannula that are placed percutaneously. The first is the in the femoral artery to access blood, and one in the femoral vein to return blood, and the gas exchange membrane is interposed in between. It is commercially available through Nova Lung, and it's called the interventional lung assist the ILA membrane. So, as said before, these systems uses the patient's own blood pressure, so they have the advantage of not requiring a pump. So they are cheaper, they cause less blood trauma, and they are more simple to handle. On the other hand, they require arterial cannulation. So they have the potential side effects of causing arterial injury and limb ischemia. It is therefore recommended to perform an ultrasound before arterial cannulation to ensure that the cannula will not take more than 70% of the arterial lumen. Venous cannulas are chosen 2 French larger to ensure a low flow resistance. These systems are heparin coated, so normally a strong systemic coagulation is not necessary. Since the part of the blood of the cardiac output that passes through the system doesn't take part to the peripheral circulation, the effective cardiac output of the patients is reduced, meaning that there is needed an arteriovenous pressure gradient of at least 60 millimeters of mercury, what makes these systems are unsuitable for patients who are hemodynamically unstable. This is a nice overview of the concept, the evaluation and the preparation, insertion and monitoring that you have to make if you use these systems. So what about the venous devices? They differ from the arteriovenous devices because you need a pump to propel the blood into the circuit. Pump and membrane lung can be separate components or incorporated into one single unit. So they are more complicated to handle and often need multidisciplinary support. Placement is also percutaneously, and they vary, the cannula vary from 13 to 17 French. And normally, after insertion, heparin is added, as also a strict heparin infusion. What's on the market? We have the pump assist lung protection, the PALP systems, which is a low flow system containing a gas exchange membrane and a blood pump. This system can be bridged into a full ECMO system by simply ruling out the gas exchange membrane into a full ECMO oxygenator. The ILA Active, which is actually the Nova Lung and pump into one device. Also, these systems can deliver a full ECMO support. So flows achieved from a half liter per minute to more than 4 liters. The Hemolung is also a low flow system which contains a membrane and a gas and a pump where a rotating core accelerates the blood into the surrounding fiber and it goes out by the outer port. And at last, the DCAP system. The DCAP system contains a membrane lung which is put into in series with a hemodialysis filter and the pump. Blood or ultrafiltrate coming from the pump is returned to the bloodstream prior to the inflow of the membrane lung, which allows additional CO2 removal. Unfortunately, there are some complications with both systems, mechanical one, like circuit disruptions and problems with cannula, but also a lot of patient-related complications, bleeding due to the anticoagulations, or thrombosis and emboli. What about these indications? At first it was designed to facilitate lung protective ventilation in RDS patients, but now the indications are extending to COPD patients as bridge to the transplant and to facilitate thoracic surgery. So let's take a look at the literature. In this nice randomized controlled trial performed by Bean, patients with severe RDS were allocated to the low tidal volume group. That means 3 milliliters per kilogram predicted body weight and an AV echo, or to the conventional mechanical ventilation, which is 6 milliliters per kilogram predicted body weight tidal volume. And in the overall, there were no differences in both groups, but a post-hoc analysis in the more severe hypoxemic patients, meaning a PaO2 FiO2 ratio lower than 150, there was a significant improvement in 60 days ventilator-free days. There wasn't a benefit in hospital mortality, and maybe that can be explained that there were 9 patients on the lung transplant list in the AV ECCO group, and also that the values at the beginning were higher in the ECCO group. Also, this systematic review where there was an equal use in AV ECCO and VV ECCO, ultraprotective ventilation, so low tidal volumes, was feasible due to ECCO. However, there was no demonstrable mortality benefit or organ failure-free days with the use of ECCO. Complications rates are varying a lot, and maybe that is because the more familiar that you got with the system, the less complications that you have. So in conclusion, we can say for RDS that ECCO is an attractive strategy to facilitate lung protective ventilation. However, we do not know what its effect is on survival. Clearly, the risk-benefits need to be clarified, and we do not know which patients cohort is the key population to target. And maybe the Supernova trial will help us with that. It is a safety and feasibility study on the use of ECCO to facilitate ultraprotective lung ventilation in patients with moderate to severe RDS. Inclusion criteria are patients with an expected duration of mechanical ventilation more than 24 hours. So moderate RDS, PF ratios between 100 and 200, and a PEEP of more than 5 centimeters of water. Primary outcome measures are to see if with ECCO tidal volumes of less than 4 milliliters per kilogram can be achieved, and to see what the baseline values will do. It is accepted that they vary 20%. Secondary outcome measures are the frequency of adverse events, the clearance of the CO2 during the first 24 hours, and the assessment of pH, PaO2, and PaCO2. So what about COPD patients? We know that COPD patients who will fail on NIF, and these patients will require a prolonged weaning and also have a higher in-hospital mortality, up to 39%. We also know that COPD patients who get intubated after failing upon NIF will have a higher mortality than those who are treated at the beginning with mechanical ventilation. So ECCO seems appealing for these patients to facilitate the withdrawal of non-invasive ventilation, to avoid the intubation, and to facilitate early weaning. And this was also shown by this nice retrospective study of Kluge. Patients who were failing upon NIF got an AV ECCO or were intubated, and with ECCO in the patients, 90% of the patients didn't require intubation and invasively mechanical ventilation. There was a trend towards reduced length of stay. Systematic review, 10 studies, almost 90 patients, showed that ECCO prevented intubation in 93 patients and assisted the extubation on 53% of the mechanically ventilated patients. ECCO does what it has to do. It improves respiratory acidosis, and it lowers the work of breathing, and complications vary among patients. So in COPD patients, ECCO as an adjuvant therapy seems appealing, certainly in patients who are failing upon NIF and These patients certainly who do not want to be intubated anymore and who do not want to have palliative care. As said before, in patients for thoracic surgery, this could be also an attractive adjuvant. This is a study by Wiebe. 6 patients who needed a prolonged discontinuation of ventilation got an AV echo, and 4 patients with emergency procedures. And adding echo was showed that there was an efficient elimination of CO2, and the procedure was successfully performed due to the echo. Also, as bridge to transplantation, it is appealing. 20 patients with life-threatening hypercapnia. Adding echo prevented intubation in 4 of the 5 patients in the non-invasively ventilated group. And it made that patients got successfully transplanted, and hospital survival was rather high, around 75%. What's our own experience? We use the ELA, so the arteriovenous devices. Till now we performed 60 patients. We do that in the COPD patients with the formally set indications. And in RDS patients with an PF ratio lower than 150. And we wanted to know if patients who got contraindications for ECMO, adding this echo was safe and feasible, what its effect was on mortality, rather high, and what was its complications. The frequency of complications is shown in here. We had 5 bleedings and problems with catheter placements. But all these adverse events didn't have any impact on the outcome. I have to mention that all of these adverse events happened with patients with high BMI. And of course, with ECCO, the evolution of pH and PaCO2 corrected in both groups. So in conclusion, we can say that ECCO is a promising therapy for treating patients with an exacerbation of COPD, that achievement of lung protective ventilation in patients with RDS is feasible, that there are difficulties in the prediction of the progression of the disease at an early stage, why this makes that this technique use is limited in clinical practice. We do not know which device is best, and the complications in ECCO balancing from bleeding and clotting events and the right use of anticoagulation is today not found. I thank you.